Hello everyone, and big thank for you for being here today. I am Khanna along with my colleague Dr. Deepika Chabra from Medical Services, Jagsonpal Pharmaceuticals Ltd. I'd like to extend warm welcome to this Scientific Sangam 25 organized by ISOPARB Prayagraj in association with Allahabad and Cannanore Obst and Gynae Society with academic partner Jagsonpal Pharmaceuticals Ltd. Makers of Divatrone, injection Maintane and Divagest, all progesterones. Please note this webinar is granted 2 ICOG points. Jagsonpal would like to thank the experts, the participants for joining us today through this webinar, The Art and Science of Birthing, Preterm Birthing. For today's scientific programs, The Art of Science of Birthing, organized by ISOPARB, I would like to welcome organizing chairperson, Dr. Ranjana Khanna, Madam. Madam is founder president ISOPARB Prayagraj. She is also the ICOG governing council member and vice president FOGSI 2017. I request Madam to kindly initiate this session.
Yeah, a very good evening to everyone. At the outset, I always begin my programs with the prayer to Lord Shiva. So to begin the program, I would like to hand over the session to Communicator ISOPARB Prayagraj, Dr. Parul Khanna. She is currently she's an IVF consultant at Nova IVF in New Delhi. So Parul, you please take over the proceedings.
Thank you, ma'am. A very good evening to the esteemed faculty and dear delegates. We begin with our 25th webinar of Scientific Sangam series under the heading The Art and Science of Birthing. And today we will be discussing in detail regarding the preterm birth. Our first speaker for the session is our founder president of ISOPARB Prayagraj, Dr. Ranjana Khanna, Madam. And she will be speaking on prevention of preterm birth, role of CERCLAGE, progesterone, and pessaries. I would now invite the chairpersons for the session. Our first chairperson is Dr. Geetha Mekoth. Ma'am is consultant gynecologist at AKG Memorial Cooperative Hospital and Dhanalakshmi Hospital in Cannanore. She is president Cannanore Obst and Gynae Society, president of WIMA Thalassery branch, and ma'am has special interest in laparoscopic and reproductive medicine. Welcome, madam. Our second chairperson is Dr. Taru Pandey. Ma'am is consultant gynecologist at Kilkari Mother and Child Care Center, Prayagraj. She is vice president WDW Prayagraj. She has been also past secretary of WDW and a life member of AOGA Society of Allahabad. Welcome, ma'am. I now request Dr. Taru Pandey, ma'am, to introduce our speaker, Dr. Ranjana Khanna, ma'am, and Dr. Geetha to give her expert comments after the talk. Over to you, Dr. Taru.
Thank you so much, Dr. Parul. Am I audible?
Yeah.
Yes, ma'am.
Okay. Good evening, everybody. It is an honor and privilege to share the screen with such stalwarts of the societies. So we all know that in 2022 statistics, it showed that 1 out of every 10 infants born in the planet was a preterm baby. And almost 1/5 of the world's preterm babies were born in India. So we know how much of a load it was of an emotional, physical, and economic burden on the nation's economy. So the topic decided for today to be spoken about by Ranjana Khanna ma'am is a very important one, which is preventing preterm birth, role of CERCLAGE, progesterone, and pessaries. It is an honor again to introduce ma'am to all of you, although all of you know her very well. But let me just put in a few words. She has been National Vice President FOGSI 2017. She is Founder President ISOPARB Prayagraj 2021 till 23. She is ICOG Governing Council member from 2021 till date. She is President AOG. She has been President AOGS Allahabad from 2013 to 2016, and she has organized many national conferences, including Scientific Sangam at Prayagraj in 2023, Obstetric Dilemmas Allahabad 2022, AOH, the Trilogy Delhi at 2017. She has been organizing Secretary National FOGSI Conference, SAVEMA 2016. She is a winner of many awards. She has won FOGSI Achiever Award in 2022, FOGSI Dhira Award in 2022, FOGSI Dr. D.K. Tank Reproductive Healthcare Promotion, FOGSI Smriti Milan Award, Save the Girl Child, AICOG 2013. She has been a faculty at various national, international conferences, and she has also conducted the IMA Excel Refresher course at 2022-23. So it is a great honor, ma'am, to invite you to start your lecture, to deliver your lecture. We are patiently waiting. Thank you, ma'am.
Thank you so much, Taru, and for the introduction. And first of all, I want to welcome all the esteemed faculty who have joined us from Cannanore. Thank you so much for accepting the invite. It's always a pleasure. And because of Shaijas, I could connect to all of you, and it feels really good. Good evening, everyone. I am going to speak on a very, very important and a very interesting topic, preventing preterm birth, role of progesterone, cervical cerclage, and PESSARY. I think my topic and Parag's is going to overlap a bit. Preterm labor is defined as onset of labor starting spontaneously after the gestation of viability and before 37 completed weeks of pregnancy. Threatened preterm labor is uterine contractions without any cervical changes. Preterm labor accounts for 43.7% of all neonatal deaths in India. Less than 10% of women who are diagnosed with preterm labor, however, would actually deliver in the next 7 days. Of all the preterm, 40 to 45% are due to spontaneous preterm labor, and 30 to 35% follow preterm membrane rupture. When we talk about the pathophysiology, the cervix develops from fusion and recanalization of the distal paramesonephric ducts, which is completed by 20 weeks of gestation and has both muscle and fibrous tissue. The fibrous tissue is responsible for the tensile strength of the cervix. Cervical insufficiency is related to a defect in the tensile strength at the cervicoisthmic junction. The risk of preterm delivery increases as the cervical length decreases. Hence, shorter the cervix, greater is the chance of preterm delivery. Short cervix is predictive of preterm birth, but not diagnostic of cervical insufficiency. And many women with a congenitally short cervix would deliver normally at term. So the etiopathogenesis. Previous history of preterm birth or late miscarriage associated with 32% chance of recurrent preterm birth. 70% of the recurrent births occur within 2 weeks of the gestational age of the prior preterm delivery. Cervical insufficiency is another cause, which could be because of cervical surgery, cervical laceration during delivery, D&E, and connective tissue disorder. Then we have infections and inflammatory response like ascending infection from the vagina and cervix, which includes bacterial vaginosis, group B streptococcus, chlamydia, mycoplasma, gonorrhea, gardnerella, etc. Systemic infections like pyelonephritis, pneumonia, acute appendicitis, periodontal disease. Uterine distension, which could be because of multifetal pregnancy, hydroamnios, which causes stretching of myometrium and initiates expressions of contraction-associated proteins. These are gene codes for gap junction proteins such as connexin 43, oxytocin receptor, and prostaglandin synthetase. They cause uterine contraction and cervical ripening. Feto-maternal stress causes elevation of cortisol in the mother, premature activation of the placental adrenal endocrine axis, increased placenta-derived corticotropin releasing hormone, increased estrogen level accelerates the cervical rightening and leads to loss of uterine quiescence. PROM is another cause. Medical factors are there like preeclampsia, GDM, uterine anomalies and other causes like low socioeconomic status, anxiety, stress, tobacco consumption, substance abuse, coitus. Now, how do we predict preterm labor? The two most promising markers are fetal fibronectin levels and ultrasound assessment of the cervical length by transvaginal sonography, which is the one which is most commonly being used. Now, fetal fibronectin is an extracellular glycoprotein, functions in intercellular adhesion during implantation and placental adherence to the uterine decidua. It is normally present in the cervicovaginal secretions up to 20 to 22 weeks. Around 22 weeks, chorion fuses completely with the underlying decidua, which prevents fibronectin to leak into the vaginal secretions. It is non-detectable between 24 to 34 weeks. So it has got, however, a very high negative predictive value of 99.2%, but its positive predictive value is much less. So TVS is the one we look at mostly, funneling of the cervix with the changes in the forms T, Y, V, and U. So it is based on the mnemonic trust your vaginal ultrasound, cervical length less than 25 mm, protrusion of membranes, presence of fetal parts in the cervix or the vagina. So there is initial very little funneling, the internal os starts opening as we can see, and then the funneling increases and finally the whole cervical canal is open. So treatment option. First of all, we'll talk about the surgical option. So the simplest way to more effective surgery is to choose the right patient. So when we talk about the McDonald sutures, this is what we are routinely doing. First performed in 1963, it is performed using a permanent suture. Cervix is grasped by the Babcock forceps. Then we take a purse string suture around the exocervix as high as possible, somewhere near close to the internal os. And then we just tie the knot anteriorly. And then this is removed at 37 weeks. Or labor, whichever comes earlier. So this is a picture showing the McDonald suture. Then we have the Shirodkar stitch, first reported in 1955 by Dr. V. Shirodkar. Many modifications of this have been made. The original technique involved a strip of fascia lata, which was just 1/4 inch wide and 4.5 inch long. And this was removed from the outer aspect of the thigh. Each end of this strip was transfixed with a linen suture, but presently we are using 5 millimeters Mercilin tape on a Mayo needle. And what is done, we make a horizontal incision. Transverse incision is made on the anterior lip of the cervix, just above, quite close to the internal os. We make a nick and then we push the bladder up, and posteriorly we take a similar nick, slightly vertical. And then from that, we introduce a needle, which is circular, and we introduce it. And then from both sides, we introduce and tie the knot either anteriorly, or this can also be tied posteriorly. And again, this is removed either at 37 weeks or onset of labor. So what are the RCOG guidelines regarding cervical cerclage? History indicated cerclage should be offered to women with 3 or more previous preterm births and or mid-trimester losses, should not be routinely offered to women with 2 or fewer previous losses. USG indicated cerclage is not recommended in women without a history of spontaneous preterm birth who have an incidentally identified short cervix of 25 mm or less. So if you just see on ultrasound that the cervix is short, less than 25 mm, don't just hurry and give a stitch. It's not indicated unless there is a history of previous spontaneous preterm birth. A history of 1 or more spontaneous mid-trimester losses or PTB who are undergoing transvaginal surveillance of cervical length should be offered an ultrasound indicated CERCLAGE only if the cervix is 25 mm or less before 24 weeks of gestation. An ultrasound indicated CERCLAGE is not recommended for mere funneling of the cervix if it is long. Serial sonographic surveillance, women with a history of spontaneous second trimester loss or preterm delivery may be offered serial sonographic surveillance because those who experience cervical shortening are at an increased risk of subsequent mid-trimester loss may benefit from CERCLAGE, while those whose cervix remain long have a low risk of mid-trimester loss. And women should be informed that you may not go in for serial sonographic surveillance. It can also be managed by expectant management. Transabdominal CERCLAGE is only done if the transvaginal has failed previously. Rescue CERCLAGE is only done when the os is already open, the membranes are already there, the bag is there, and it is only to be done by a very senior obstetrician. In this, we take the patient and put her in the extreme Tredelenburg position. The patient's lower part is elevated, and then the obstetrician takes a Foley's, and especially if the membranes are bulging, and then she takes the bulb of the Foley's and places it very close to the membranes and then gradually inflates the bulb. That will push the membranes gently up, and the obstetrician can easily apply the suture without including the membranes in the suture. So this is the way, but the chances of success are very less in these cases. And CERCLAGE is not routinely recommended in multiple pregnancy and uterine anomalies and cervical trauma. So what are the contraindications of CERCLAGE? The contraindications are active preterm labor, clinical evidence of chorioamnionitis, vaginal bleeding, PPROM, evidence of fetal compromise, lethal fetal defect, and fetal death. Complications could be membrane rupture, preterm labor, hemorrhage, infection, but these are uncommon with prophylactic CERCLAGE. There is no role of perioperative antimicrobial prophylaxis and tocolysis. Now coming to the next part of it, cervical PESSARY. Most commonly used is Arabin. Others that have been tried are ring PESSARY, Hodge, and donut. What is the mode of action? It presses the internal os closed from behind and changes the inclination of the cervical canal. So the weight of the gravid uterus is directed towards the lower anterior uterine segment rather than the cervix. So it protects the cervical mucus plug, thereby preventing ascending infection. Arabin PESSARY is round, cone-shaped, flexible silicone PESSARY. Dome-shaped, resembles the vaginal fornices, hence it encircles the cervix. It has perforations in the silicone for drainage of the vaginal discharge. Comes in various sizes. Mode of insertion, it is lubricated, squeezed between the thumb and fingers at the time of introduction into the introitus, unfolds inside, and the smaller part of the ring should face towards the cervix, and it is placed in such a way that the cervix protrudes through the inner ring as seen in this picture. Removal is easy. It is done at 37 weeks, or if delivery is imminent. If contractions are effective, cervix is pushed back through the inner ring of the dome and the cervixes, and the PESSARY is very easily removed. So the results are very good with PESSARY, and the best part is it is non-invasive, no anesthesia required, no foreign body, reduced risk of infection, no effect of tearing of cervical tissues, no pressure necrosis of tissues, changes the uterocervical angle, so direct pressure is on the anterior segment. Prevents direct pressure on the membranes, protects the cervical mucus plug, so lesser chance of infection, may be left in situ in case of rupture of membranes for conservative management. It is very easy to remove. Now, coming to vaginal progesterone. Progesterone has an essential role in maintaining pregnancy, primarily through establishing uterine quiescence. This is achieved through suppression of the calcium carmodium myosin light chain kinase system, reducing calcium flux and altering the resting potential of the smooth muscles. Mechanism of action is at various levels, and in patients of preterm labor at the placental level, it acts by regulating the timing of the labor via controlling stress hormone. In amniotic fluid, it limits the prostaglandin production. At the fetal membrane, blocks the pro-inflammatory cytokines, and at myometrium and cervix suppresses the inflammatory response. Which progesterone? There are progesterone tablets, which we all are using, 300 milligram sustained release tablets OD. Pessaries are there, which can be inserted vaginally. Vaginal gels are there, 17 alpha hydroxy progesterone caproate weekly, and injection NMP, 100 milligram every third day. So what are the criteria? International guidelines. French guidelines 2016 say that if it is an undilated or cervical length is less than 25 mm, vaginal progesterone should be used, 200 milligram pessaries per day at night, or 90 milligrams gel, duration from 24 weeks to 34 weeks. This is level A evidence. FIGO 2015 says cervical length again less than 25 mm, screen between 19 to 24 weeks, vaginal progesterone, 92, same as above. And Strategy 2015, they say the same thing, except they want to continue progesterone till 37 weeks. ACOG 2012 says that it's the same, but they also add in intramuscular progesterones. And similarly, we have the SOGC guidelines. Now, when we talk about the vaginal progesterone guidelines, these are updated 2019. So offered to patients with history of prior preterm birth, less than 34 weeks and mid-trimester losses 16 weeks onwards. Results of TBS at 16 to 24 weeks of gestation shows a short cervix less than or equal to 25 millimeter, and start at 16 to 24 weeks and continue at least till 34 weeks of gestation. These are the 2019 guidelines. When we talk about Society for Maternal Fetal Medicine 2017, they say that in 2017, in women with a singleton gestation and a history of prior spontaneous preterm birth between 20 and 36 weeks of gestation, we recommend 17 alpha hydroxy progesterone caproate starting at 16 to 20 weeks of gestation until 36 weeks of gestation or delivery, and the vaginal progesterone should not be considered a substitute for 17 alpha hydroxy progesterone in these patients. So meta-analysis was done. Vaginal progesterone decreases preterm birth and neonatal morbidity and mortality in women with a twin gestation and a short cervix. So the conclusion was that administration of vaginal progesterone to asymptomatic women with a twin gestation and a sonographically short cervix in the mid-trimester reduces the risk of preterm birth occurring at less than 30 to 35 weeks, neonatal mortality, and some measures of neonatal morbidity without any demonstrable deleterious effects on childhood neurodevelopment. This was published in 2017, and this article is a US government work. So now for prevention of preterm labor, vaginal progesterone and CERCLAGE. Now we are comparing the two. Vaginal progesterone and CERCLAGE are equally effective for preventing preterm birth and improving perinatal outcomes in women with a singleton gestation with previous spontaneous preterm birth and mid-trimester sonographically short cervix. The choice of treatment will depend on adverse events and cost effectiveness of intervention and patient or physician preference. Now, a randomized trial was done on oral micronized progesterone, 400 milligrams OD for prevention of recurrent spontaneous preterm birth. It showed a trend towards reduction in the recurrent spontaneous preterm birth with increase in maternal serum progesterone levels. Now, when we talk about this Indian experience of CERCLAGE versus progesterone, pregnancy outcome in short cervix, progesterone versus cervical and CERCLAGE. So 50 cases were taken, 25 progesterone and 25 CERCLAGE was given. So what did they find? They found that NMP is as effective as cervical cerclage in prevention of premature labor in a woman with singleton pregnancy with a short cervix. Now, see, NMP is preferred because no surgery involved, no hospital stay, does not need an expert obstetrician. The patient can do it at home. It's much more economical, no surgical complications. So using vaginal progesterone saves time for the patients as well as for the doctors. Dafoniska in 2003 did a study. 142 women with prior preterm birth prophylactic cervical cerclage uterine malformations were given 100 milligrams progesterone suppository with a blind placebo trial. The same investigators 4 years later studied 413 women with a short cervix, given 200 milligram progesterone suppository from 24 to 34 weeks. In both the studies, there was significant reduction in the preterm birth in the progesterone group. No RCT, however, has directly head-on compared vaginal progesterone and cervical cerclage in cervical insufficiency. 4 studies evaluated vaginal progesterone versus placebo and 5 evaluated cerclage versus no cerclage. And they found a significant reduction in the risk of preterm birth. Afirvik et al. Into 2013 compared 2 cohorts of women with previous preterm births and a short cervix. 142 women with cerclage, 59 women with vaginal progesterone. No significant difference in terms of perinatal loss, neonatal morbidity or preterm birth. However, there was a higher rate of birth before 34 weeks if we were using vaginal progesterone as compared to the cerclage group. So FIGO guidelines. Sonographic cervical length measurement should be performed in all pregnant patients at 19 to 23 weeks of gestation using TVS. This can be done at the same time as a level 2 scan. Women with a sonographic short cervix less than 25 mm diagnosed in the mid-trimester should be offered daily vaginal micronized progesterone treatment for the prevention of preterm birth and neonatal morbidity. The progesterone formulation should be vaginal micronized progesterone nightly or vaginal micronized progesterone gel, 90 milligrams in the morning. Universal cervical length screening and vaginal progesterone treatment is a cost-effective model for preventing preterm birth. So what is the evidence on which FIGO recommends progesterone prophylaxis in women with a short cervix? There is the prolonged trial published in October 2019. No significant change on the rate of preterm birth or neonatal morbidity in the groups comparing the patients treated with 17-hydroxyprogesterone caproate against placebo. Optimum study was done comparing vaginal natural progesterone versus placebo in the following outcomes: improving obstetrical outcome or improving neonatal outcome. And they found that vaginal progesterone did not have any significant effect on any of the primary outcomes. Moreover, subgroup analysis of women with a short cervix showed no significant interaction between the cervical length and the outcome. In other words, women with a short cervix did not respond better or worse to progesterone as compared with any other woman in the study. Progress study was done. Compared the outcome of randomly divided patients managed by vaginal progesterone versus placebo. No difference in the primary outcome, which was the incidence of RDS in newborns. So to conclude, the National Institute of Clinical Excellence in the UK, FIGO and SMFM in US all recommend the use of progestrogens for women at high risk of preterm birth. The latter advises that women between 20 to 36 gestational weeks, we've talked about this, 17-hydroxyprogesterone caproate, and the 2 former organizations endorsed the use of vaginal progesterone for women with short cervix. Now, this is the latest advisory by ACOG, April 2023. They say that there was not sufficient data to indicate 17-alpha-hydroxyprogesterone caproate an effective treatment in all pregnant women with prior spontaneous preterm birth. But whether this treatment would benefit a subset of women requires more further studies, more future studies would be based on that. FDA decision, however, is not based on the safety concerns. So probably there are no safety drawbacks with 17-alpha-hydroxyprogesterone. Natural micronized progesterone is as effective as cervical cerclage in prevention of preterm, premature labor in a woman with singleton pregnancy with a short cervix. Cervical cerclage showed more benefits than vaginal progesterone for women with an asymptomatic short cervix and prior PTB history, while cervical cerclage and vaginal progesterone therapies showed similar effectiveness for women with a short cervix, but without a history of preterm birth. Use of MNP is preferable in clinical practice because it is non-invasive, easy to administer, and there are no surgical complications. Thank you so much.
Thank you, ma'am, for such an elaborate talk. It was very well, it included everything. I now request Dr. Geetha to give her expert comments.
Good evening, esteemed guests of Cannanore Society and Allahabad Society. Thank you, Ranjana Madam, for the invite. Thank you, organizers of Prayagraj, for the invite. Preterm delivery is a nightmare for each and every obstetrician, especially if the patient is elderly, IVF, and with comorbidities. Ranjana Madam has given a wonderful, precise, and clear talk on preterm birth, its prevention, CERCLAGE, and PESSARY. It was very nice, Madam.
Thank you so much.
Thank you for the invite, Madam. It was a very wonderful talk.
Thank you so much, Dr. Geetha.
I now hand over my session to Dr. Amita Tripathi, ma'am. She is founder, honorary secretary of ISOPARB Prayagraj.
Thank you, Parul. Very warm welcome from my side also to all the faculty and delegates. Welcome Cannanore Society. And moving towards the second session, the topic is managing preterm birth. And it will be covered by the speaker none other than Dr. Parag Binewale sir. And to chair the session, we have Dr. Ajit sir and Dr. Bhavya Ebe. It's an absolute honor to introduce Dr. Ajit sir. He is additional professor, Government Medical College, Tirunelvelim. He is president, Kerala chapter of RCOG, coordinator of confidential review of maternal nearness committee of KFOG, past president of KFOG, and past president of Cannanore OBGYN Society. Welcome, sir. Dr. Bhavya is secretary of Cannanore OBGYN Society, and her area of interest is oncology and quizzing. She has got prize in the best paper for in oncology in ICOG conference and Viva FOGSI South Zone. With this, I request Dr. Bhavya to please introduce our speaker, Dr. Parag Binewale sir.
Thank you, madam, for those kind words. It's indeed a pleasure to introduce such an eminent speaker of our nation, Dr. Parag Binewale. He's a senior consultant in OB-GYN in Pune. He's PG teacher and unit head at Kamala Nehru Hospital. And he was the president of Pune OB-GYN Society, president of Pune OB-GYN Society from 22 to 23, vice chairperson ICOG 21 to 23, president of Menopause Society of Pune 2018 to 22, secretary of ICOG from 2018 to 20, national website editor of FOGSI from 2011 to 17, and he's a peer reviewer of Journal of Obstetrics and Gynecology of India. He's a chairman of Young Talent Promotion Committee, FOGSI, from 2008 to 2010.
Good evening. I bring greetings from Pune, and it's indeed a pleasure to be joining Prayagraj again. I think I was part of the first program also. So thank you, Dr. Ranjana, founder president of ISOPARB Prayagraj, for considering me as a speaker. My warm regards to Dr. Manju Verma, madam. Thank you for joining. And a big hello to Allahabad OBGYN Society and Cannanore OBGYN Society. Again, Cannanore is a place I have not visited, but I've been there twice virtually. Right. So in next 15 to 20 minutes, I'm going to talk about the nightmare that is the preterm labor. Dr. Ranjana has beautifully explained us what we are supposed to do to prevent it. And, you know, our science always tells us that we should do whatever best we can to prevent whichever clinical condition that we have. And then if we can't prevent it, then we have no choice but to treat it. or manage it very, very carefully. All of us know that preterm birth is a big challenge, and whenever there's a childbirth which takes place before 37 weeks of gestation, we say that it's a preterm birth. And world over, we know that there are 15 million preterm births taking place, and they contribute to more than 1 million neonatal deaths. That's a huge number. And 35% of those are from our country. And that is the reason why we should be very, very particular about preventing, treating, managing it in time. And it is not about only death, because there are babies who survive, but then they do face a lot of challenges like RDS, sepsis, IVH, necrotizing enterocolitis, and all this adds to the morbidity plus mortality in some of these babies. So we have to first recognize the factors which can be associated with preterm birth. Now we know that whenever we are dealing with a multifetal pregnancy, which generally is the outcome of fertility treatment, here there is uterine overdistension, and theoretically the woman is more prone for landing up in preterm labor. Similarly, if there's a history of preterm labor, we should be really vigilant and do our best to prevent it. Maternal stress, we know that most of the girls nowadays are working, and the work pressure plus the stresses of pregnancy add to the misery of preterm labor. Let's not forget the PPROMs, or women who smoke, and the ascending infections which contribute to preterm labor. And whenever we think of risk factors for preterm labor, we must take detailed clinical history, especially if there is a history of mid-trimester loss, find out whether there was a pre-labor, pre-rupture of membranes in the preterm delivery that the woman had. Was there any history of cervical treatment for cervical intraepithelial neoplasia? Ask for the imaging record if she has short cervix, if it was present on a transvaginal ultrasound. So any of the risk factors listed here would be a trigger when we think of a pregnancy, or these are the women who would land up in a preterm birth. And let's not ignore small symptoms with which women come. So if she comes with a symptom like, say, menstrual-like cramping, and on examination, even if the uterus is relaxed, please keep in mind that, well, this could be heading to a preterm birth at a later date. So if she has mild irregular contractions, low backache, pressure sensation in the vagina or pelvis, or if she complains of vaginal discharge, which could be of any color or any consistency, don't take it lightly. Give due importance to it, especially if the woman complains of spotting or even light bleeding. And evaluating the patient is extremely important. First of all, determine the correct gestational age. Wrong dates is something which at times creates a lot of confusion. Determine whether the labor has begun or it is imminent, and is any early intervention indicated. Now, if the mother has chorioamnionitis, well, we may not prevent preterm labor, but use appropriate antibiotics, use whatever measures that you can, and then treat the baby. Or if you are dealing with a cord prolapse or a placental abruption, then we need to treat it rather than conserving it. And fetal presentation will guide us as to how we are going to terminate this particular pregnancy. So when we do an initial assessment, determine the gestational age, whether the membranes are intact or rupture, is the patient in labor, rule out any kind of infection, and what is the likelihood of premature delivery. And when we look at this in toto, we take a call as to what exactly is the treatment that you're going to offer the patient. Coming to digital examination, something which at times is controversial, but please understand that cervical digital examination is important because it will tell us about the cervical dilatation and effacement. Of course, we won't do it in a woman who has placenta previa, or even women who present to us with history of rupture of membranes. For speculum examination, if you are suspecting that there is something which we need to do. For example, if there is a abnormal fetal heart pattern, or if we realize that the woman may be in an advanced phase of active labor, rather than putting in a speculum, do a digital examination first. Role of ultrasound, Dr. Ranjana has already talked, but this is something which we have to use to our help, and it will be helpful in taking good decision at the right time. Of course, when we do it, assess the fetal status, fetal weight, assessing the amniotic fluid is extremely important, and the biophysical score will be reassuring if you are contemplating a conservative management. Let's not forget certain investigations. We would definitely do a hemogram, CRP, something which many of us are doing. Urine culture sensitivity is extremely important because we may be dealing with a woman with asymptomatic bacteriuria or even pyelonephritis. Do testing for sexually transmitted infections. The Westerners love to do group B streptococci, and I don't think many of us are doing it. And fetal fibronectin is something which definitely has a role to play these days, but it may not be available at all places. So whenever we are suspecting that the woman is approaching or if she's in preterm labor, first of all, examine the patient, determine the gestational age. Now, if the gestational age is more than 34 weeks, do not give tocolytics. Antenatal corticosteroids may not be of great help, but there's no harm in administering them because they will even prevent transient tachypnea of newborn at a later date. Admit the patient for delivery if the labor progresses, and if it doesn't progress, then of course, when the contraction cease, the woman can be asked to go home. Now, if the duration of pregnancy is less than 34 weeks, do a digital examination. If the cervix is more than 3 centimeters dilated, well, we are dealing with a woman who's in preterm labor. Offer tocolysis, what we are going to talk about it a little later. Antibiotics for GBS prophylaxis, again, something which Westerners are using. Not many of us are not using antibiotics routinely. Magnesium sulfate, Shajas is going to talk, so I'll not deal with it. Antenatal corticosteroids should be administered between 23 to 34 weeks. But in our scenario, if the duration of pregnancy is between 26 and 34 weeks, we would certainly offer it. Now, if the cervical dilatation is less than 3 centimeters, then it may be a good idea to obtain a specimen for fetal fibronectin testing. Take help of ultrasound, determine the cervical length, and depending on the cervical length, take a call as to what treatment that you're going to offer. So if the cervical length is less than 20, or if the cervical length is between 20 to 30 with a positive fetal fibronectin, we know that she's in preterm labor and treat it. But if she is not likely to be in preterm labor, we would certainly admit her, observe her, do not give her any specific treatment. And if the contractions cease, she may be asked to go home and take due care. So these are some beautiful guidelines which all of us must refer. And when we talk about management of preterm labor, these are the tocolytic agents that we tend to use. Beta agonist is something which is extremely popular in our country, and most of the obstetricians are using it. Calcium channel blockers, my personal favorite. Magnesium sulfate does have a role, more so in the neuroprotection, less commonly in arresting preterm labor. Indomethacin, very, very popular in the Western countries, not very commonly used here. Atosiban is the new kid on the block, which is rather an expensive one. So which agent to choose? This is a $1 million question, because what we believe that whatever is available, whatever is the best possible treatment that you wish you can offer to the patient, go ahead and do it. So by all, nifedipine and atosiban are supposed to be safer than the beta agonist. So when do we start the tocolysis? So tocolysis has to be started immediately. as soon as you make a diagnosis of acute preterm labor and continue it till the steroids act or till the fetal maturity takes place or for an intrauterine transfer. So rationally, tocolysis should be offered for a duration of around 48 hours. So when we talk about tocolysis, there is good amount of literature which talks about delaying birth for 48 hours or delaying birth for 7 days. So these are two interventions which may be of a certain benefit to the baby, but delaying birth up to more than 37 weeks is something which is at times difficult, but may be attempted if the patient agrees and if the clinical scenario are useful, then maybe we will have lesser chances of respiratory distress or even neonatal death. Coming to the first drug, and that is atosiban. I personally do not have much experience of using atosiban. This is supposed to be quite useful. The Westerners feel that it is not very great. It does have an important role to play, especially if the patient is in active labor. The one which we have used and we still prefer to use is the calcium channel blocker, and that is nifedipine. We usually start with a 20 milligram stat dose, repeat after 30 minutes, and then this can be continued every 8 hours for about 48 to 72 hours. When we are using nifedipine, we are always worried about the maternal or the fetal effects because of the drug itself, but it is found that nifedipine is safe and effective in prolonging preterm labor and has minimal maternal and neonatal side effects, and it eliminates the need for intensive maternal monitoring as required in the case of beta mimetics. Isoxaprine is something which was in vogue and which is still in vogue by many practitioners. They use it as an IV infusion, and the drip rate should be around 30 to 45 drops per minute, can be increased, and depending on the contractions, we decide whether to increase the dose or to reduce the dose. Monitoring vitals is extremely important. These women may suddenly develop hypotension. Don't forget pulmonary edema if you are overloading the woman with isoxaprine. So in general, beta sympathomimetics have been the most frequently used drugs to arrest preterm labor. Let's not forget that they are potent vasodilator drugs. The ACOG recommends beta sympathomimetics as the first line treatment for management of preterm labor, and there's good evidence which talks about tolerability of the drug used both as acute and maintenance therapy. So this was a data which was published recently, and then it talks about how isoxaprine was found to be effective and a well-tolerated tocolytic agent in arresting preterm labor, and this in fact resulted in overall improvement of maternal and perinatal outcomes. Terbutaline is something which a few of us have used, so it reduces the chances of preterm births within 48 hours to 7 days, but not up to 37 weeks. It can reduce the chances of RDS, but there is no impact on the neonatal death. Don't forget the side effects, because again, terbutaline can cause tachycardia, hypotension in the mother, and fetal tachycardia, and even neonatal hypoglycemia. So you have to be really vigilant when you are managing these babies. And safety profile of all these drugs is extremely important, and we should keep this chart in our labor rooms whenever we are using tocolytics to our women. Each drug has its own share of benefits and more side effects. So pick and choose the drug which you are comfortable with and administer it very, very carefully for the duration of time that is desired. So whenever these women come to us, the next question is, now you have arrested the preterm labor, then you plan to send her home. Then the set of questions that these women will ask: what about day-to-day activities? Yes, she can continue day-to-day activities. A big no-no to travel or sexual activity. exercise has to be limited, whatever little exercise she's doing, no heavy workouts. About the work that she's doing, so we must encourage women to avoid returning to work if they are working for more than 40 hours per week. So that includes our doctors also. So whenever we get any OBGYN's resident who is pregnant and with a possibility of threatened preterm labor, then we must advise her to be at home. There are certain interventions we tend to offer, but they may not be of great help. In fact, there is no proof that they will work. The first is maintenance tocolytics. We tend to continue tocolysis for a longer duration of time. In fact, one of my students did submit his thesis for DNB when we use tocolytic agent that is nifedipine, and what we found out was we could prolong the pregnancy for up to 2 to 3 weeks without causing any effects to the baby. Role of antibiotic prophylaxis, unless there is evidence of infection, no prophylaxis with antibiotics is required. If you have arrested preterm labor, do we start progesterone? There is limited evidence and it may not be of great help. And antepartum fetal surveillance should continue as per the risk factors. Just because you have arrested a preterm labor, that does not qualify the baby to offer intensive fetal surveillance. Neuroprotection, I'm not going to talk. Prevention of preterm birth, Dr. Ranjana has very beautifully elaborated all the points, but let's not forget the progesterone, because there is ample evidence that hydroxyprogesterone, caproate, and micronized vaginal progesterone do have an important role to play in prevention of preterm birth. The problem area that comes is multiple pregnancies, and here we may offer whatever we can, but it may or may not help. So especially if you are dealing with a higher order multiple pregnancy, we know that 30% of triplets will deliver before 26 weeks, and then the outcome will be really poor. So it may be sensible to reduce triplets to twins in order to have a better outcome, but there's no evidence to support a reduction from twin to a singleton pregnancy. So vaginal progesterone for prevention of preterm birth, especially in twins, and this was a study where okay, coming to the recommendation, I know it's a busy slide, but this is what the literature supports, and we must try and do whatever best we can in order to prevent preterm birth. So this is a busy slide, but it talks about use of progesterone suppository. It talks about hydroxyprogesterone caproate, which we usually initiate between 16 to 20 weeks and continue till about 36 weeks. And it also talks about micronized vaginal progesterone in the dose of 100 milligrams every day, or even vaginal gel. Emergency CERCLAGE has its own place. So whenever we are dealing with a preterm labor, of course, it is important that we stop the contractions first, then reassess the patient, and then take a call whether this particular patient requires cervical CERCLAGE or not. This definitely has an advantage over the no stitch group. So we may consider a womb stitch or a modified McDonald's stitch. The steroids are saviors, and we must administer 2 doses of steroids. So dexamethasone, 12 milligrams, 2 doses repeatedly after 12 to 24 hours, or betamethasone, or rather betamethasone 12 milligrams, 2 doses, and dexamethasone 6 milligrams, 12 hourly for 4 doses. It is indicated in all patients except when there is frank chorioamnionitis. What about one course or repeat course? Previously, we used to administer it weekly, but I'm sure everybody sitting here will agree that one course is good enough. If a good time has lapsed between the first dose and a repeat evidence of preterm labor, we may think of giving an additional rescue dose. It has tremendous benefits and very, very few risks. PROM is something which again is a big challenge, especially the preterm PROM. So here we have to try our best to prevent infections, give something to enhance lung maturity, decide if the continuation of pregnancy is safe or unsafe, and monitor the mother and the baby to deliver accordingly. So giving antibiotics is something which is important. So we may consider giving antimicrobials which are safe and effective. Ampicillin given every 8 hours for 48 hours, followed by erythromycin, is the drug of choice. Avoid co-amoxiclav, but in general, cephalosporins are found to be better. So it is really important to make a decision, especially when you're dealing with preterm PROM. There could be reasons for us to wait. So in order to achieve a good fetal maturity, for the steroids to act completely, to give a good antibiotic cover, intrauterine transfer to a higher center, and of course, there are some points that we need to intervene if there is onset of labor or if there are any acute complications, and of course, to prevent fetal complications. So delivering a preterm fetus is a big challenge, and these are some of the factors that we need to consider. The big question is whether to do a C-section or to deliver vaginally. So it has to be a balanced decision. Of course, cesarean section does not necessarily improve the neonatal outcome. So offer best possible care to this woman who's in preterm labor. Electronic monitoring is of great help. Give antibiotic cover. Do your best to offer an atraumatic delivery, so no vacuum, but we can consider applying the forceps if needed, and presence of neonatologist is a must. Cesarean in preterm deliveries is a big challenge, and the lower segment is poorly formed, and these are the babies, these are the patients where extensions are likely, and of course there could be a lot of bleeding. And this is one app which helps in evaluating the impact of triagic women at risk of spontaneous preterm births. I personally do not have any experience with this, but since I found this interesting, I thought I must share it with all. So to conclude, preterm birth is a preventable problem. Vigilant monitoring and aggressive treatment is essential. Progesterone, nitrile micronized progesterone, or 17-hydroxyprogesterone caproate, has an important role to play in prevention of preterm birth. Tocolytics have a role in acute preterm labor. Steroid administration is a must, and cervical cerclage has its own role in preventing preterm birth and should be used judiciously. Thank you very much, and once again, thank you, Dr. Ranjana and the team, for having me yet again in Prayagraj.
Wonderful talk, Prayag. Yeah, Dr.
Very excellent talk. Excellent talk. Anyway, he has covered everything about the management of preterm labor. And again, once again, I would like to thank the Parag ISOPARB for involving Kannur Society also in this talk on a very important topic, the commonest cause of perinatal morbidity and mortality.
Yeah, I wanted to ask anyone who has some experience of using atosiban for as a tocolytic.
Not personally.
Atosiban is now available in India.
Yeah, it is available. Yeah, there was a lot of hue and cry about it being an excellent drug, but I am still on isoxaprine only.
But the evidence from the UK is that the atosiban is not that useful. Maybe our own nifedipine and terbuterol may be more effective. So I think even the nifedipine will be very relatively harmless drug, which can be used.
True. Ajit, when I was preparing for the lecture, I was going through literature, and what I found out was that atosiban was the second generation, or I should say that it was not considered as the primary therapy.
Yeah.
It was considered as a secondary therapy for arresting preterm labor. So whenever, whatever literature that is available still has nifedipine and tocolytics, so terbutaline, ritodrine, etc. And the Americans, I think, are more fond of indomethacin. I personally do not have any experience with
and indomethacin is actually a good drug, but it should be used only before 28 weeks. After 28 weeks, the problem is the contraction, the premature flosion of the ductus surface.
Yes. Right.
But it's very effective drug.
But nifedipine, I feel, causes severe headaches also in patients.
Yes, typically for first 36 to 48 hours, but then it subsides. So whenever we start,
but till she has that headache,
it is terrible. It
is debilitating, absolutely debilitating. Yeah. So I still prefer the age-old, good old isoxaprine.
Most of us. You have to
most
use
of the patients tolerate nifedipine. Most of the patients.
Hanji ma'am, aap boliye.
We tried Motilal and one of the consultants were using, and we did not find it an edge over the isoxaprine. Besides, there were much more complications, so we again drifted back to the isoxaprine group. Or nifedipine, yes, has been started as one of the drugs of choice for threatened with preterm. But etosiban, one thing is it is very costly.
Yes,
it is
so really expensive. And if you give that to the patient, especially in private, and God forbid if the preterm labor does not subside, then you've had it.
That was the biggest problem. Plus, there was, the side effects and the efficacy was almost similar to isoxaprine, so we shifted back to isoxaprine.
Yeah.
What about this corticosteroids? Anyway, as you rightly mentioned, the repeated doses is not necessary.
No, repeat. At least I have never repeated. But
25 years ago, we used to give it weekly. So which was
I just have one thing to say, Parag, that if we have already given one dose of steroid, right? So that means the lungs are mature. Then why do we have to repeat it again to remature the lungs?
No,
the lungs are already matured.
It's just a rescue dose. It's just a rescue dose that you give. So just a single dose.
If the last dose is given after 2 weeks before the delivery, you can give a rescue dose. That is all.
Yes, that's
okay.
So 10 weeks is the maximum time of the effectiveness of corticosteroid when giving
10 weeks. No, but Acha, tell me one thing. If the lungs are already matured once, they won't go back.
No, look,
and then you again remature them. So I'm always confused as to why the rescue dose is given. Because once the lung is matured, it's matured. So how does it go back to the original form?
Ranjana, there's a number of things which have to mature. It is not only one thing that has to mature, right? So the thing is that if you give it at 24 weeks, suppose.
No, not 24. I'm not talking about that early. I'm talking about like 32, 33 weeks.
Giving. If the delivery occurs
if it is 32, 33 weeks, there's no need to. Because
no need
the days of giving steroids routinely before 39 weeks.
And Parag, you were saying there's no role after 34 weeks, but we are giving till 37 weeks also.
See, if you look at the RCOG guidelines, I'm sure Ajit will also agree with me that if you are posting a patient for elective C-section before 39 weeks, RCOG guidelines recommend.
Yeah, it was given, but now recently they changed.
They've changed now.
Yeah. After 34 weeks.
So additional
after
advantage.
34 weeks, even the RCOG is saying that there is no place for routinely giving steroids.
After what
only thing is you can discuss with the patient. The only benefit is that it decreases the hospital admission, the NICU admission for the respiratory distress.
Yeah. And then the transient tachypnea of newborn also reduces one.
Yeah, that is the only advantage.
Yeah.
But there are long-term complications of giving steroids after 34 weeks is there.
Yeah.
So better avoid. That is the thing.
After 34 weeks, we are supposed to avoid.
Yeah.
But with NICU facilities, often it's risky. So I always give before 37 weeks, I always give. Actually, I give, frankly, before till 38 weeks I'm giving, if I'm doing a surgery. Just to be on the safer side.
Babies of new generation are maturing early, madam. So no need to worry beyond 34.
37, we were maturing, so they will be maturing even earlier.
Yeah, even when they come out also, they show all that, right, from the early life.
There are
The other
long-term
concern,
neurological issues with the giving steroids near time. So that is the worry. There are a lot of neurological issues that can come long time. So if you give it after 34 weeks. So
what are the complications, sir?
The neurological complications,
Okay.
the IQ, everything. So
Okay.
the patients can sue you later. So be very careful about giving steroids near time.
Okay.
the other concern, if I can just add a point, basically these steroids were expected to work in the gradual process of maturation of the cells. Okay, so that is why dexamethasone and betamethasone were timed so beautifully. Betamethasone every 12th hourly, the other thing. Unfortunately, many times whenever there is a concern that a patient might deliver very soon, these dosage schedules are generally not followed. Both doses are put together, 24 milligrams is given together as a start dose and all that. Now, if you are not actually following the protocol and if you have not been able to give those 4 or 2 doses, depending on whether you have been using dexamethasone or betamethasone, then this process of maturation might still not have happened completely. So that is actually a concern. So it's not a good idea to actually go away from the protocol and try to give everything as a combined dose and all that. It actually has to follow that regime. Definitely. Only then the maturation rate will coincide with the amount of steroid that you're giving, and that is going to create an impact on the lung maturity, which is going to stay there for quite some time. So that is just a point which I just wanted to add.
And then the challenge with the dexamethasone is that the one which is available is 8 milligrams.
Yes.
And then you have to give a dose of 6 milligrams. So
yeah.
Eventually we end up giving 4 vials and wasting little drug from it.
Yeah.
I know it's not very expensive, but then still it is. So maybe Deepika, you can take this up and come out with a 6 milligram dexamethasone.
And the betamethasone is probably the one which is good is the one betamethasone phosphate, and we don't have that in India apparently.
No.
Actually, there should be 2 salts for the betamethasone, acetate and phosphate. That is available in Western countries, but unfortunately, we have is the only one salt.
Only one.
So the duration of action is only 6 hours, 6 to 12 hours for the betamethasone that is available in India. So that is why we are recommending dexamethasone in India, that is 6 milligram, 12 hourly, 4 doses. That is the one that is recommended. And another thing is that dexamethasone is more stable. So it is more heat stable. So for the transportation, all these things, that is why Government of India is recommending dexamethasone over the betamethasone.
So should we give or should we not give?
We should give. It is a very good drug, but limited to 34 to 35 weeks. After that, be very careful.
But after that, you know what happens that when the pediatrician comes to attend, then they see a child at 35 weeks, they'll say, ma'am, have you given the steroid course for lung maturation? And if not, then you take
a printout of the recent RCOG guideline and give it to the pediatrician.
Do you think the corticosteroid only has the effect over the lung maturity and it is not affecting the other organs? Like the brain, I think
it is even inflammatory hemorrhage, everything decreases, but before 34 weeks, not after that.
Not after that.
It can even be given with the newborn for neuroprotection. I think Shrejas will be able to tell us more in detail about neuroprotection, in which they are trying corticosteroid to be given.
So you all are not giving after 34 weeks. If the patient comes at say 35 weeks, then you all don't give steroid for lung maturation.
No.
Parag, what about you?
We give.
We give also.
No, because then again the transient tachypnea of newborn, because that is something which is again unpredictable. So, touch wood, but we've not seen any serious side effects.
Yeah, I've never seen any adverse effects.
Yeah. rather than.
But it has to be given with caution, especially in cases of GDM or.
Yeah, of course.
Preterm preeclampsia also, because there the lung maturity also occurs earlier. So
Yes.
you don't need to give it before 34, after 34 weeks.
After 34, yes, correct. Right.
Again, diagnosis of preterm labor should be very correct. Sometimes you should not, especially you should not miss a dangerous condition like abruption. So be careful about.
Okay. Thank you, Parag sir, for such a lucid talk, and thank you, chairpersons, and all others for pitching in and for the wonderful discussion. With this, I request my dear friend and Secretary of Allahabad Obstetrics and Gynecological Society, Dr. Uma, to conduct the last session.
Thank you, Dr. Amita. And Dr. Ranjana ma'am, warm welcome to all faculties on board. Good evening, one and all. Now we are moving to our last session of the day, that is neuroprotection of preterm birth. The speaker of which is Dr. Shaijas. Chairpersons are the teacher of the teacher par excellence, past president UPCOG, professor and head of the department, MLN Medical College, Prayagraj, past president AOGS.
I am a family member of AOGS. I think that is what
family member of AOGS.
Introduction.
And always loaded with the advanced knowledge in the field of Obst and Gynae and every turn. None other than Dr. Professor Manju Verma ma'am. Our second chairperson is Dr. Shubha Pandey ma'am. She is president AOGS 2324. She is head HOD Kamla Nehru Memorial Hostel of
Thank you, Uma.
and
That's enough.
Prayagraj.
Uma, that's enough. Thank you.
Thank you, chairpersons. Now I request Dr. Shubha Pandey ma'am to introduce our speaker, Dr. Shaijas.
Welcome, Dr. Shaijas, and a good evening. He has done his MS from Jitner, and he is chairperson Midlife Management Committee of FOGSI 2021 to 24. He's joint secretary Kerala Federation of Obstetrics and Gynecologists 21 to 24. Past president Cannanore ONG Society. He's a fertility specialist and has won many awards and recognitions. SN Joshi Women Empowerment Award, Mrs. Shailja Pandit Women Empowerment Award, Signature Social Reformer Award.
Madam,
Meera
I think we can
Award.
keep it there.
So many awards. Welcome, Dr. Shaijas. He's going to speak on a very important topic, that's neuroprotection in preterm birthing. It will involve the strategies and interventions which are aimed at minimizing or preventing neurological damage in infants born prematurely. The earlier the gestational age at birth, the greater the vulnerability to neurological complications. Now, this is an active area of research and clinical practice. And so now over to Dr. Shaijas.
First of all, thank you so much to ISOPARB Prayagraj, especially Ranjana madam for this special invite. Such a pleasure to always collaborate and do such programs, because we're talking about a very important entity called preterm birth and its implications. Yeah, so I bring greetings from my FOGSI team, headed by the vibrant president Hrishikesh sir, Madhuri Patel madam, the secretary general, my vice president Dr. Yashodhara Pradeep, and the midlife management committee. I also bring greetings from this vibrant society of Kannur, 130 plus members doing some tremendous amount of work on both the academic as well as on the non-academic social fronts. And I bring greetings from the Kerala Federation, of which I'm the joint secretary at this point of time. So wonderful to collaborate with ISOPARB Prayagraj. So we're talking about neuroprotection in preterm birth. When Ranjana madam called up and told about this topic, I just remembered that I had given a lecture on the same topic in 2011. That is almost 12 years back. And that incidentally was in Kannur at a time when I was not part of Kannur Society. And that was the All Kerala Congress that happened at that time in Kannur. And this was my topic there. Those were the days when people used to view this topic in a very skeptical manner, because people weren't very convinced. I remember that Dr. Geetha Arjun was sitting and listening to my lecture with hardly any other people in the hall, because this was not of much interest at that point of time. And I was a very, very small person at that time, and I remain so even today, I believe. So why are we talking about this today? I think we have already discussed this. Both the speakers have brought out this particular point, that the burden of being born too early is just too much. 13.4 million, if you look at the latest WHO data in 2020 alone. And preterm birth complications are the leading cause of death if you take children under 5 years. Fortunately or unfortunately, 3/4 of these deaths could have been prevented by some cost-effective interventions. And whenever we talk about prematurity, it is not just about death. Even those children who survive, they need to face a lifetime of disability, including learning disabilities and visual and hearing problems. And that is why we need to discuss about this topic much more than anything else. One is about preventing it, and the other part is when we can't prevent, try to do as much as possible to ensure that if they happen to survive, they are born with less amount of disabilities. The word cerebral palsy brings a lot of things to our mind, primarily because it's the leading cause of neurological impairment in a young child. And we understand from evidence that preterm birth and low birth weight are the most important risk factors for developing cerebral palsy. Fortunately, years before, almost 12, 13, or even more years before, they found that in utero exposure to magnesium sulfate before an early preterm birth does reduce the incidence of cerebral palsy and this entity called severe motor dysfunction in the offspring. And that is from where this entire concept of neuroprotection got kick-started. Magnesium is never an unfamiliar drug as far as an obstetrician is concerned. We have primarily used it for two indications. One is for treatment and prevention of eclampsia, and the other is as a tocolytic agent. And evidence would agree, and all of you listeners would agree, that as far as treatment and prevention of eclampsia is concerned, it's been very effective. But for the other indication as a tocolytic agent, it is not so effective, as Dr. Parag rightly pointed out. Now, there's been a lot of proposed theories, and some of these theories still remain proposed, but we know that it does make a difference. So what are those theories? I remember that I had a similar slide in 2011 also. But the change from 2011 to 2023, when I am giving this lecture again, is the amount of evidence that have happened beyond that time, the good trials that have come up, as well as critical review of these trials that have happened beyond that period of time. So all these have gathered into much better quality evidence and much better understanding of a few questions that we had at that point of time, which we could not answer well. Stabilization of cerebral circulation by stabilizing blood pressure and by normalizing cerebral blood flow is a proposed theory. Prevention of excitatory injury by stabilizing the neuronal membranes and by blocking excitatory neurotransmitters like glutamate is another proposed mechanism. Magnesium, as you all know, has got antioxidant effects and anti-inflammatory effects, and thereby it can protect against oxidative injury and inflammatory injury respectively. So these are the proposed mechanisms. So you're looking at stabilization of cerebral circulation. We are looking at prevention of excitatory injury.
I'm sorry, I just...
No worries, madam. No worries. We'll break
but
now.
Dr. Pai has joined.
Yes, we'll listen to sir. Good evening, sir. Good evening, sir.
Yeah, a very, very warm welcome to you. I mean, literally warm because it's very hot here in Allahabad. So I hope you are through with your surgery.
Yeah.
Yeah, so I would like to formally introduce Dr. Hrishikesh Pai, who is, I think, one of the most dynamic and popular presidents of FOGSI ever. Currently, he is, of course, president of our Federation of Obst and Gynae Societies of India, founder and medical director, Bloom IVF Group, chief administrator, FOGSI Manyata Project, and he's editor of Indian edition of British Journal of OBGYN, editorial board member, And he's got so many awards and so many achievements, received 59 awards, including honorary FRCOG Fellowship of the RCOG Eminent Physician Award, National IMA Award, Mogs BN Purandare Award, Kanak Goyal Community Service Award. I think, Dr. Pai, you must be having another house just to put all these, mementos and awards that you have. And past position, and he's the editor of 17 plus books, contributed lots of chapters in various books and delivered so many lectures and 20 plus orations, many research papers. And he has achieved, gotten ISAR Lifetime Achievement Award also. Past position, he was past Secretary General, Senior Vice President, Deputy Secretary General and Treasurer and Chairman FOGSI. Past President ISAR, IAGE, Mumbai OBGYN Society, Maharashtra Chapter of ISAR, Assistant Treasurer, Director Corporate Affairs, IFFS, International Federation of Fertility Societies, Adjunct Assistant Professor, Eastern Virginia Medical School, USA, past Professor D.Y. Patil Hospital and Leelavati Hospital, Honorary Consultant, Bhaba Municipal General Hospital for 17 years, and founder chair, Indian SIG, American Society of Reproductive Medicine, and founder editor, IAGE Journal of Gynecological Endoscopic Surgery. So over to you, Dr. Pai, and please give us your views on this webinar that we are doing on preterm birth. And of course, anything you want to talk about FOGSI, we are all ears.
So thank you, madam, for introducing me. You're a wonderful person, and we are looking forward to your conference in Prayagraj in December, and it will be lovely. I'm really because it's always cold and wonderful and beautiful in the north in the winter season, and you are all very affectionate. We always feel that all the people in the north are very affectionate, loving, respectful, it's very, it's good. These are all important things of life. काम तो हम करते रहते हैं, उसमें कोई बड़ी बात नहीं है, पर ये सब जो आप करते हो, खातिरदारी करते हो, अच्छा रिस्पेक्ट देते हो, वो बहुत इम्पोर्टेंट, सबके लिए बहुत इम्पोर्टेंट है, सबके लिए वो मायना रखता है. Anyway, so nothing, we are doing very well. I was just telling this to my patient, one of them was asking me, I said, do you know that there are 30 million deliveries that take place in India? And of those 30 million, 50,000 may be IVF related deliveries. So it's a very small, tiny part of the overall thing, the overall maternal health care in our country, and that's why probably the ministry and the state is very too busy to give us licenses. All the IVF centers are having problem because they are too busy with the larger, broader maternal health which is there, which is very important for us, because women's health parameters and women's development is a very important part of the government's policy. Of course, they want to not only take care of women, but they also, the whole India's status is dependent on various parameters like GDP, growth, economic development, infrastructure, and women's health also. So that women's health is considered a very important parameter to place our country in a good position in the international eyes, and all that gets reflected in other things of life also. More people start coming to the country, more people start working with the country, more people have got faith in the country that if they invest money in our country, that money will not go waste. A lot of people have a lot of faith in our country, and one of the reasons because of that is our healthcare is doing very well. So healthcare is very important, and maternal health is very important. As far as maternal health is concerned, of course, maternal mortality is a very important parameter. Means whatever I've learned from going all over the world, or whatever I learned in my FOGSI, interacting with various aid agencies like WHO, USAID, Bill Gates Foundation, and all these foundations. So there are 5-6 important things that they look in healthcare. In mothers, in malaria is important, tuberculosis is important for them, contraception is very important, family planning. Then SHRH, especially abortion, is a very important parameter. Then maternal health is very important. And within maternal health, presently they are focused on anemia. Just now, I was talking to the Dr. Tuli, Mrs. Tuli, who is the chairman of the Thalassemia Society, and I said that, Madam, what the other societies are very important. ISOPARB is very important. IFS, ISAR, but FOGSI is a mother society. So if at all national policy is there, we have to deal with FOGSI. And one of the things I feel, and we are going to have a committee, and Dr. Ranjana, I'm going to put also in a part as a committee, that we have to recommend. So if we have to eliminate the thalassemia, and which is Mr. Modi's very important project, thalassemia and sickle cell. So what we'll have to do is that we will have to do routinely HB electrophoresis for everyone. So that will help us to do two things, kill two birds in one stone. So any entry point, so 30 million women are there, we will do the hemoglobin electrophoresis, which will also help us to differentiate whether the anemia if she's suffering for is because of thalassemia, sickle cell, or iron deficiency. So, and I told her that we will have to, so we will, all the patients who 30 million will come to us every year. Beside blood group, hemoglobin, anti-D, whatever, and then we do that HIV and all triple H we do. We will also do HB electrophoresis. Now that costs about 1,000 rupees MRP, but maybe if we do it, cost price will be 500. So I said that you privately, suppose out of the 30 million, 2 million, 3 million, let's say 4 million will do the test on their own. Remaining people, government is anyway going to do the test. So let us do the test. We give us the addresses. We will give it to all our 266 societies where you will do the test free of charge. So it's because Mr. Modi has allotted money to eliminate sickle cell by 2047. Nirmala Sitharaman has already allotted money in the budget. So I told her that so we are going to have a meeting in the next few days. So we will talk with us. We'll have the secretary also of health, and we'll say, okay, we will do it as a routine. So we are going to recommend it routinely. And those who can't afford it, will give it an address. Now, I have also put one more clause in it. I said, those who don't want to, suppose you say you go to Allahabad government hospital, they may not want to go. Now, who will go to Allahabad and stand in the line? So I said, we will also connect with 5-6 blood collection, big chains like Metropolis, Lal Pathology, Pharmacy, where for 300 rupees, they can collect the blood and give it to the government for testing. So that's how I'm planning it, a large scale project with the government. So we'll be able to catch them at the entry point. So if the thalassemia is positive, then we'll do the thalassemia test for the husband also. Yes. If he is positive, and not only that, if the thalassemia is positive, we can go back and do the test for the entire family also. So I said, we are the point. You want to pay the money, give it to us. Give it to the federation. Give the money, we will do it. This is another point I am already arguing with the government. I said that why don't you give maternal health implementation to the federations to do? Actually, you have Ayushman Bharat, give it to the federation. So if there is a black sheep in our federation, he will not do cheating if the federation is monitoring. Because federation, it is इज्जत भी कुछ होता है ना. आप कुछ लफड़ा करेंगे तो फेडरेशन आपको जूते मारेंगे. तो फेडरेशन को देना कंट्रोल, आयुष्मान भारत का कंट्रोल आप फेडरेशंस को देना, लोकल सोसाइटी को देना. Allahabad society will control the fund. So if there's a Ayushman Bharat patient, the Allahabad society can decide whether this is a proper money to give or not. Let the societies get the control. So anyway, there's a lot of, but the exciting part is that the government has started listening to us. Every meeting they call me, I get so excited. And sometimes I feel, so, it's very good. I'm very happy. FOGSI has got a very good position in the government at present. And it's very nice to have a good feeling that we are helping in the development of a country. So anyway, I don't want to take much of your time. There's a lot of issues that are there. But maternal health, your society, ISOPARB, is mainly dealing with maternal and perinatal health. And that's the most important part of our overall maternal health which we have got. So you are in the best society. And just now in the morning only I phoned Dr. Maji, and I got the conference in November 24th to 26th November. I want to invite all of you. So we will come to the November conference, and then we'll all come to the December conference.
December conference, exactly.
So both the conferences are our conferences. And we invite you.
I've
all.
already invited the Cannanore Society people. I said,
Yes,
you all
yes,
are most welcome.
I know Cannanore has also joined you in this meeting. So, you know, I was telling someone, I'm so happy that we are all FOGSI members, and, you know, they don't know our commitment, towards FOGSI and towards maternal health. So, wish you the very best. And I'm sorry that I came late, but I was.
No, der aaye durust aaye.
Okay, madam. Thank you.
Thank you
And
so much, Dr. Rishi, for joining.
All of them, Amita Tripathi ji is there, Shaijas is there, Dr. Manju Verma is there, Uma Jaiswal,
thank you, sir.
Geetha, Mekoth, Ajit, our great Ajit from Kerala, wonderful gentleman, Dr. Pandey, Dr. Chabra, and all of them, Taru Pandey, Bhavya, Dr. Shubhada Pandey, all of them are there. So wish you the very best and hope that you have a great meeting. Thank you.
Thank you so much, Dr. Pai. Thank you so much, Rishi.
Okay, bye-bye.
Bye. I think we are again looking forward to hearing the remaining part of your presentation.
Very much. I think you've all been neuronally a little bit more energized with what Dr. Pai had to say. So that sets the tone. Sir's inspiring words are just like a cup of tea that is being served in between a meeting, no? So the speaker who gets to speak immediately after the cup of tea gets the maximum attention. So I take it that way. So I was just talking to you about the proposed theories of how magnesium works, and primarily on the stabilization of the cerebral circulation by stabilizing the blood pressure, prevention of excitation, especially by blocking excitatory transmitters like glutamate, and then prevention of both oxidative injury as well as inflammatory injury, because it's got antioxidant and anti-inflammatory effects. Okay, fine. Now the evidence regarding whatever we know as far as use of magnesium for neuroprotection of a preterm baby is concerned comes from three major trials. One is the Australasian collaborative trial of magnesium sulfate. You can call it ACTO-MGSO4. The other is the beneficial effects of antenatal magnesium sulfate trial, which is called the BEAM trial. And then we have the PREMAG trial. So as far as evidence for effect of magnesium for the neuroprotection of the preterm baby is concerned, it's primarily about these three trials. This shows a little bit in elaboration of these three trials. I know it's a busy slide and not a very easy one to read, but I just want you to note that ACTO-MGSO4 had almost 1,000 plus subjects, BEAM trial had almost 2,000 plus subjects, and the PREMAG trial around 500 plus. Just remember that BEAM trial had used a higher dosage, and the other two, ACTO-MGSO4 and PREMAG trial, had stuck on to the lower dose regime, and PREMAG trial did not use a maintenance dose. So those are the primary things to catch from the slide, and we move on. Now, what is the inference from that evidence that is available now? Now, they looked at a few parameters. If you look at the parameter called any type of cerebral palsy, and the other parameter being moderate and severe cerebral palsy, both these parameters were significantly reduced with a relative risk of 0.71 and 0.64 respectively on those babies where magnesium was used for neuroprotection. The other parameter that they looked at was substantial gross motor dysfunction. This was found to be significantly reduced in both the groups. Overall would mean that it included all trials where magnesium was used for a variety of indications, not just for neuroprotection. And the neuroprotection subgroup trial would mean that they have taken only those three trials, which I have mentioned earlier, where magnesium was given for the intended purpose of neuroprotecting the newborn. Okay. And this parameter called substantial gross motor dysfunction was significantly reduced in both the groups with a relative risk of 0.61 and 0.60. The other parameters that were looked at were death or cerebral palsy. That was not found to be significantly reduced in the overall group, but was reduced in the neuroprotection trial subgroup. Just a word about this parameter of death or cerebral palsy. Remember that these are so-called competing outcomes. That means a diagnosis of cerebral palsy is possible only if death has not happened. So they are exclusive components, they are competing outcomes. Okay. And that also was found to be reduced in the neuroprotection trial subgroup with a relative risk of around 0.85. The other parameter that was looked at was stillbirth or pediatric death, which was not significantly reduced overall in the neuroprotection group as well as in the overall group. Which are the candidates for magnesium therapy as far as providing neuroprotection is concerned? Women who present with imminent preterm birth and who are at a period of gestation of 24 to 34 weeks. They are the candidates. And what is imminent preterm birth? It is defined as a high likelihood of birth because of active labor with a cervical dilatation of 4 centimeters or more, with or without PPROM, preterm premature rupture of membranes. The other set of candidates are the ones who have been prepared for a planned preterm birth, either for fetal or for maternal indications. So these are the candidates for therapy. Now the upper limit, should we give till 32 or should we give till 34? It's very controversial as the discussion that happened just prior to this talk about antenatal corticosteroids. Now, if you want to come to a conclusion of whether 32 or 34, you just need to remember this entity called numbers needed to treat. That is the number of pregnancies for which you need to give magnesium so that you prevent one cerebral palsy. Okay. Now, if you take that subgroup between 32 and 34, the number of pregnancies where you need to give magnesium so that one case of cerebral palsy is prevented is 56. Now, if you change that subgroup to period of gestation of less than 30 weeks, that NNT reduces to 46. Okay. So the higher and higher you keep the upper limit of gestational age, the NNT also will be more. That's the only thing you need to realize. So you can keep it 32 or 34, depending on where you want your NNT to be. Fine. Now the dosage, the most important part. The IV loading dose is 4 grams. The maintenance dose is 1 gram per hour infusion. And that has to be given for at least 24 hours. It is given till birth or for 24 hours if birth has not occurred. Now, how to give? I think during our undergraduate days, we always used to remember how to dilute this, isn't it? Now, 4 gram dilution will be very simple, just like how we do that for while we treat our eclampsia and pre-eclampsia patients. A 4 gram IV loading dose, 4 gram means 4 ampules, that will be 8 ml. You add another 12 ml and that becomes 20 ml and that becomes a 20% solution. You can give it very slowly over 20 minutes, or more easily, you can just add that 4 ampules in 100 ml of saline and run it over 20 minutes. Okay. The maintenance dose is 8 ampules, that is 8 grams, and that will be 16 ml. Add another 34 ml and make it 50 ml because the syringe that you generally connect in an infusion pump is a 50 ml syringe. And then you keep the rate at 6.25 ml per hour. And that will let magnesium reach the patient at 1 gram per hour infusion. As you rightly said, there are preparations available now, so you are spared of the dilution problems. But I still wanted to mention this because for those centers who do not have that, we will still go by the traditional way of remembering this and diluting. So either of the options are available, but remember that the loading dose has to go over at least 20 minutes because they have attempted at the incidence of side effects when it was given over 5, over 10, and over 20. They found that at least over 20 would be the best time in which a 4 gram IV loading dose can be given. So that is the thing to be remembered. Fine. Now, there is a higher dose regime which was used especially in the BEAM trial, which was a 6 gram loading dose and a 2 gram per hour maintenance dose. But that was supposed to show significantly higher side effects and the safety profile was not found to be good. So we will just stick on with this low dose regime, which is this particular regime that I've just mentioned. Now, magnesium, is it safe? I think the first answer that would come out from all of you would be that it is safe. Sometimes when you just leave it there, the problem is we don't tend to remember what can actually go wrong, at least in those rare circumstances. So that's why I just added this slide just to make sure that magnesium, though it is considered to be safe, even the loading dose is safe, even for those women who tend to have a renal impairment, okay? but we still need to know what can actually go wrong, the major side effects, as well as some of the minor ones, so that if it happens, you'll be able to pick it up. Now, the life-threatening side effects are cardiac and respiratory arrest, which you all know. That is why we monitor these patients who are on magnesium, but that is very, very rare. So that way, it is a very, very safe drug to use. But you need to remember that those women who are on magnesium have a 2 times higher risk of developing hypertension, tachycardia, respiratory depression, discomfort at the injection site, drowsiness, headache, dizziness, mouth dryness or thirst, and blurred vision. 5 times at risk of nausea and vomiting, flushing or warmth and sweating, and 15 times at risk of itching, tingling sensations, as well as muscle weakness. So remember that these side effects are possible, though it happens in rarity. If it happens, I think you still need to pick up. But again, the take-home message about from this slide would be that magnesium is still a relatively very safe drug to use. Fine. Now, extending the duration of the loading dose does reduce flushing and warmth. That's why I told that you need to spread it at least across 20 minutes and not shorter than that. So take time, have a look at the clock, and then give the loading dose so that you don't end up with too many problems. And most of these adverse effects are transient and they disappear with treatment cessation. How do you monitor for toxicity? Something that every obstetrician should know. Because it's a very learned audience, I need not actually elaborate much on that. So monitoring should be at least once in 4 hours. You are looking at pulse rate, blood pressure, respiratory rate, urine output, and deep tendon reflexes. And you obviously get alert if your knee jerks are absent, respiratory rate is going down less than 12 or 14, SpO2 goes less than 95%, and urine output goes less than 30 ml per hour. Fine. Now, words of caution is contraindicated only in myasthenia gravis, which is itself a very rare condition. And magnesium has to be used in caution in those with myocardial compromise or in those with cardiac conduction defects, because it's got anti-ionotropic effects, as well as in those with an impaired renal function. I would add on and say that even in women where you have not tested for their renal function, even if they have impaired renal function, a loading dose of magnesium still doesn't harm them. So it's reasonably very, very safe to give. What are those must remember data, which is something which I didn't have when I was presenting in 2011, but today I have, because there is so much of clarity that I've come across. And these are some very common situations that we encounter while we are giving magnesium for neuroprotection. Some extra bit of data that we need to know. Now, you need to reserve this therapy for pregnancies which are at high risk of birth within the next 24 hours. As Ajit sir rightly pointed out, we need to be doubly sure about our diagnosis of an imminent preterm birth, because we also want to avoid it in those where the diagnosis of preterm labor itself is questionable. So just because a nursing staff is calling up and telling you that there seems to be some pain, I think we need not jump and start magnesium straight away, because anyway it's going to be given for 24 hours and you need to time it well so that you get the maximum neuroprotective effect. So ensure that your diagnosis of preterm labor is reasonably good. When a preterm cesarean section is planned before labor, that's a planned cesarean, okay? A planned preterm CS before labor. Now, the general consensus was just give a loading dose 4 hours before and then go ahead and do a CS. But there is more data that is coming on this. So the best timing would be administer a loading dose so that you can aim for a maintenance therapy of at least 6 to 12 hours before you do your CS. That is when you can maximize the neuroprotective effect. So just 4 hours before giving 4 grams may not be enough. You can get a little bit more of neuroprotection if you can time your loading dose so that the baby can actually get a maintenance therapy of almost 6 to 12 hours of magnesium, and then you do a CS. That's something which I can add on from the lecture which I used to give earlier. Whenever there is an emergency, as far as delivery is concerned for maternal or fetal status, delivery should never be delayed for the sake of giving magnesium. That has to be very clear. Now, if you have an induction policy which is going to take time, there are many centers who give some misoprostol in the morning, then they see the patient next morning. Okay, slow kind of cervical ripening and induction process. Now, if you're planning for something like that, do not start magnesium immediately. You can at least wait till your cervix is getting a little bit more ripe. Okay, so if you're dealing with an unfavorable cervix, an unfavorable score, Bishop score for your cervix, wait till it gets ripe, and then you start magnesium. That will be a much more logical and more useful and logical decision making. Now, this is the other thing that everybody wants to know. Exposure to magnesium, that the last dose of magnesium reaching the patient within 12 hours of delivery was associated with a reduced odds for cerebral palsy compared to an exposure that was terminated more than 12 hours before delivery. That means if you have finished your 24 hours quota, 12 hours before the actual delivery happening, then you are actually not getting enough neuroprotection. That is why you need to time it well, so that the last dose of magnesium, the last exposure to magnesium is at least within 12 hours of the probable delivery that is going to happen. How long to give magnesium? Does 6 hours of magnesium makes a difference? Does 12 hours, or does it have to be 12 to 18 hours of total magnesium therapy? Now, there is some clarity on that too from the secondary analysis of the BEAM trial. They found that there is no difference in cerebral palsy or neonatal death rates when the duration of magnesium exposure was less than 12 hours, 12 to 18 hours, or more than 18 hours. But at the same time, I would add on that at least 6 hours of maintenance therapy is good enough for adequate neuroprotection. So keep it for at least 6 hours, and anything more than that is equally beneficial. Now, even today, we do not have much evidence to say that there is a need for a repeat dose, just like what we were talking about antenatal steroids. So do not administer more than one course of magnesium sulfate for neuroprotection because we do not have much data. Now, it was only the BEAM trial which looked at retreatment. And they considered that when it was a pregnancy which was less than 34 weeks, and when the initial magnesium infusion was discontinued at least 6 hours before. That was then when they considered a repeat treatment, a retreatment. But still evidence is not sufficient enough. So I think you can use your discretion to decide whether you want to give it or not. So better than that would be make sure that your diagnosis of preterm labor is good so that you can give magnesium for the adequate duration of time that is possible. Now, if tocolysis is indicated on these women who are getting magnesium for neuroprotection, the most effective tocolytic agent with the most favorable side effect profile should be administered. And evidence would say that that is not magnesium. Okay, I'm sure that this is an additional point for many, because many still believe that magnesium is a very effective tocolytic agent. So if you are giving magnesium, why give another tocolytic agent? I would repeatedly say that magnesium is not a very effective tocolytic agent, though it's a very effective agent as far as treating and prevention of eclampsia is concerned. So if you really want tocolysis in your patient, if there is an imminent preterm birth, you should use a better tocolytic. Now, when you're thinking of better tocolytic agent, the first drug that we go to is generally nifedipine in most centers. So when you're giving a calcium channel blocker, along with magnesium sulfate, I think you should also be considered about the increase in risk of symptomatic hypocalcemia, hypotension, and cardiac suppression that can happen. So combined use should always be with caution. Though many times in practicality, nothing goes wrong. Nifedipine is still a safe drug, even when it is given for a patient who's actually getting magnesium. So before I conclude, some take-home points on whatever I've been talking. So in utero exposure to magnesium sulfate before early preterm birth does reduce the incidence of cerebral palsy and severe motor dysfunction in the offspring. Women who present between 24 and 34 weeks with imminent preterm birth are the candidates for therapy, as well as those who have been planned for a prepared for a planned preterm birth for fetal or maternal indications. 4 grams of IV loading dose over 20 minutes. Do not forget that 20-minute period, and 1 gram per hour infusion for the next 24 hours, given till birth or for 24 hours if birth has not occurred. Monitor respiratory rate, urine output, and deep tendon reflexes. If delivery is an emergency for fetal or maternal reasons, it should not be delayed to administer magnesium sulfate. Exposure to magnesium within 12 hours of that childbirth was associated with reduced odds for cerebral palsy. So do time it well. No difference in cerebral palsy as far as the duration of magnesium exposure was concerned, less than 12 hours, 12 to 18 hours, or greater than 18 hours. But still ensure that if you can plan so that the pregnancy gets at least 6 hours of exposure, that will be good enough. Do not administer more than 1 course of magnesium sulfate in neuroprotection because we have very limited data and we did not have any evidence to support a repeated dose. So those were my take-home messages, and that was my talk. And before I conclude, just to add on, why I did stick only to magnesium was, for the time being, it appears to be the only proven neuroprotective agent. Now, what are the other measures that we have? Now, there is a lot of animal studies that are happening. There are a few human studies which have looked at delayed cord clamping as a measure so that more mediators get transferred onto the baby, and that can additionally provide some extra bit of neuroprotection. But with a preterm or a combination of a preterm and low birth weight baby, we need to look at the pros and cons, whether that additional load of blood, whether the premature heart can handle, and all those things which you need to look at, and that has to be decided in consensus and still not being proven, but that is some measure. They are also looking at the estrogen-progesterone balance at the time of delivery, whether that can be manipulated, because there are certain ratio of estrogen and progesterone at the time of delivery in the woman that can actually help the baby get neuroprotected. So these are the areas where the entire world is thinking on. Okay, but for the time being, magnesium appears to be the only effective agent that is available. Stem cell therapy is probably going to come up in a big way. That is the other way to probably neuroprotect the newborns that are going to be born in the future or born for the future. So these are the other agents. I did not bring that directly in because there's not much of evidence. A lot of it is animal studies, especially regarding the estrogen progesterone exposure. And the few human studies that we have is only related to delayed cord clamping and a little bit of evidence from stem cell therapy also.
Cord clamping, unless the maybe the neonatologist wants the baby early on for resuscitation. So that will depend more on the neonatologist at that time.
True.
Thank you, Dr. Shajas. It's such a lucid and excellent talk. Now I request Professor Manjuba ma'am to say something.
Thank you, Dr. Shajas, for giving us such a detail and everything in the minute details of everything that should be done to neuroprotect a child. Now, I would like to say one thing, that because the literature saying, the PubMed says that it should be given for 24 hours if you are giving for neuroprotection. For preeclampsia and convulsion, seizure protection, you can give it for 24 hours, but there are studies which are saying that it can only be given for 12 hours, 1 gram 12 per hour, 12 for 12 hours. That's one thing I would like to say. I think you can add on to what I have read through PubMed. This was a study that was being done. The other thing is that you commented on delayed cord clamping. The human studies have also come up, and there's a meta-analysis in 2012 which says that conducted on 738 infants born between 24 to 36 hours. And there are 15 eligible studies, and they say that the incidence, lower incidence of intraventricular hemorrhage, necrotizing enterocolitis, and transfusion anemia. So if we can do it, I'm not saying that it is I'm contradicting you. No, this is one thing which we can do on our at our level. That is one thing. Another thing that is coming up is the milking of the cord, which we used to do in our times.
I know.
So if we can do some such things which are not economically quite viable. So these are the things, and there are so many other things which are coming up for the neuroprotection. Erythropoietin is coming, insulin growth factor is coming, and interleukin is coming. So many things are coming, but magnesium sulfate is the mainstay, and other things can be added. Even erythropoietin has been tried as protective for neuroprotection. So there are human studies in which they say, but yes, in our scenario, we cannot think of such things. So till then, magnesium sulfate is the mainstay, and it should be given with a caution and with precaution. Thank you. Thank you, everyone.
Madam, totally agree.
There are some questions, Amita,
yes,
in the
yes, ma'am. There were
chat box.
three questions. First for you, that was dose of hydroxyprogesterone caproate for preterm.
For me?
Yeah.
Oh, 250 milligrams IM weekly.
And thank you, ma'am. And for Dr. Parag, how do you overcome hypotension when you administer nifadipine as a tocolysis?
Actually, we don't see much hypotension. It's only a theoretical thing.
Yes. And
the
last
chances
question.
of hypotension is basically there when there is a very high blood pressure, Then if you give and you don't take precaution, then the chances of becoming hypotensive
Another
is
thing is when you give sublingually, it may be.
Yes.
Sublingual. So oral, nothing.
So,
Madam, with the retard, when we giving retard tablet, the hypertension is not much more.
I think sometimes headache is a
retard, so
concern.
slow release is there.
I think sometimes headache is a concern. Headache.
Yes, headache is
Headache are horrible.
First day or 2 days.
Horrible they are.
I think
horrible.
I think when you prescribe itself, I think it's better to tell the patient. Otherwise, she get totally psyched out.
Yeah.
Because there is no other reason. Suddenly, she starts feeling that throbbing sensation within, and it can disturb her. So
I know it's horrible.
The third question is for Dr. Scheizers. Neuroprotection for triplets before 32 weeks.
yeah, basically they're not thinking in terms of changing the dosage depending upon the number of babies, because our aim is to ensure that we reach sufficient maternal magnesium levels, and we ensure that it has got some really good transplacental passage. So it's going to benefit the babies also. So definitely need to be given, be it singleton pregnancy.
And same dose, no problems.
Yeah. Sir, is there any alterations that is being done, practically speaking, for multiple pregnancies? I think Ajit sir would be...
No. Same dose. Another thing is you should not compare this with the steroid. As Shai just rightly mentioned, you have to make sure that it's a preterm labor and should be given within 12 hours of delivery. There is no point in giving magnesium sulfate for 24 hours and she delivering after 1 or 2 days.
The levels in the mother of magnesium will be the same. So distribution to both the babies will be the same, right?
Yeah.
So I don't think there should be any change that should be there in the doses.
Doses will not affect the number of gestation.
Yeah. For the time being, we do not have any evidence also. And just to add on to what Manju Verma madam was basically telling, though there are a lot of human studies which have looked at other agents, no madam, they have primarily looked at some of the cerebral complications which tend to happen, something like an intraventricular hemorrhage. But whether that directly relates to neuroprotection is a very important question that we need to answer, because that's why neuroprotection is generally not judged by the intracerebral complications. It is judged by what happens much later. And that is only in terms of whether there is a cerebral palsy happening or there is a gross motor dysfunction. So that is why defining neuroprotection itself is a very difficult thing. And that's why how to assess that becomes even more difficult. That's why there are a lot of human studies which looked at a lot of agents which can actually reduce the intracerebral complications in a premature baby. But whether they can, to any extent, be called a neuroprotective agent, I think that is where we need to think twice. And that is why even in a lecture, we do not try to bring in any doubtful points, because people will forget magnesium and start switching over to the other things, because there is a general tendency that way whenever you get to hear new things. So primarily what we want to convey is basically the age-old magnesium is still the only proven neuroprotective agent. Everything else is experimentary at this point of time. So we'll just stick on to our practice.
You know, this triplet question is something the same as somebody once asking that in twins or in triplets, will the dose of antenatal steroids be increased? So no, it's not that. What do you say, Dr. Ajit? I think it's the same thing, you know, that it's not the number of babies that are there.
Yeah.
And I feel somehow that multiple order pregnancies, the babies tend to mature faster.
But they are also concerned that they tend to deliver earlier.
Yeah. Over distension.
So I think with this, we have come to end of this wonderful scientific session. And
wonderful talk, Shaijas.
Yeah.
Thank you so
much.
Thank you so much.
Yes. Gynae. So after this very enriching scientific session, The time has come for vote of thanks to each of you who have made this evening more memorable. My utmost sincere gratitude to our chief guest, Dr. Hrishikesh Pai sir, for his presence and blessings, who has always motivated us to do much more and more for the life of the women. Thank you, ICOG office, for granting us points always. And my thanks to our chairperson, Dr. Manju Verma ma'am, Dr. Ajit, Dr. Shubha Pandey ma'am, Dr. Geetha, Dr. Taru, Dr. Bhavya, for your valuable inputs. My utmost thanks to our speakers for today, Dr. Ranjana ma'am, for a lucid talk, as always, and always motivating and guiding us and leading from the front. Dr. Parag sir, your talk was very informative, and you have covered all the points very precisely and wonderfully. Dr. Shaizes, you were brilliant as always. Thank you, Dr. Uma and Dr. Parul, for coordinating with me. And thank you, Allah. I can't thank enough Cannanore Society and Allahabad Society for holding our hands. And thank you, Dr. Deepika and Amit, for always supporting us and giving us technical support. And all the thanks to dear delegates for joining us and the great numbers and making this scientific evening memorable and a evening to remember. Thank you so much, everyone.
A few of our brands that would be useful for this, especially for the preterm birthing. So a legacy of 32 years, we have injection Maintane, that is 17 alpha hydroxyprogesterone caproate, 200 and 500 mg for threatened and habitual abortions as well as preterm delivery. We have recently launched Divatrone. It is indigenous API and an indigenous formulation that Jagsonpal brings to you with a shelf life of over 36 months. Do support us for micronized dydrogesterone as well. Make it a legacy in the making. This Divatrone has already won the Marketing Excellence Award of AVEX last November.
And the first runner-up is Divatrone from Jagsonpal.
All with the help of support from all the doctors that we are getting. We are the progestin people. Jagsonpal has micronized dydrogesterone, 17 alpha hydroxyprogesterone caproate, allolestrol tablets, also as Maintane tablet 5 mg. Then we have the full range of natural micronized progesterone, Divagest SR 200 mg and SR 300 mg oral tablets. Then we have Divagest 200 mg soft gelatin capsules for vaginal use, and we have injection Divagest, that is injection, IM injection of progesterone. We also have norethistron controlled release as Cyclorec CR10, and we have plain Cyclorec 5 mg tablets as well. And then Dynogest, that is our Endorec. So Endorec 2 mg tablets for endometriosis. So the progestin people, Jagsonpal, do continue your patronage to Jagsonpal. Thank you so very much, and we hope to see you again.
Thank you.
Bye.
Thank you.
Bye-bye.